effects. That's the effects that it has on the heart and the effects that it has on the kidneys. Patients with Fabry's heart disease and renal disease, those diseases on their own increase the risk of stroke and contribute to the stroke burden in patients with Fabry's. Renal disease, when I started doing these talks 15 years ago, this was the most common cause of long-term serious complication. It's now been supplanted by cardiac disease, but certainly renal disease is an issue in Fabry's disease that we're concerned about and that obviously we screen for and follow. The majority of what I'm going to talk about is about cardiac manifestations, and we will talk about the different parts of the heart that are affected. This is showing a still of an echocardiogram. I'm just going to move that so I can see. And this is a very thick intraventricular septum. It's about double the normal thickness. This is actually an MRI. And again, the wall thickness here is extreme, close to double what you'd expect for a patient that age. One of the reasons that patients with Fabry's are missed is that when they are young, and what this is showing you here are the age in the dark bars at which patients recall having had symptoms attributable to Fabry's disease, and then the white bars are the age at which there was actually a diagnosis made. And because most of the early manifestations are quite non-specific, if you don't have an actual mutation in the family to cue the physician into looking for Fabry's, it's very hard to diagnose. The result is that many people have more than a 20-year lag between when they had actual symptoms attributable to Fabry's disease to when they actually had a diagnosis made. This is probably illustrated better on this slide. This is showing age along this axis and the different types of symptoms, and you'll see the pain attacks, the keratomas, the sweating, the abdominal pain. Most of these are happening in relatively young people. Certainly these are manifestations the patients will know about. The things that are easier to attribute specifically to Fabry's disease, such as the kidney disease, the renal failure, the cardiac problems, and the stroke, are occurring much later. And this is why there's often a 20-year delay between when you have symptoms that are from Fabry's but non-specific to when you actually have a diagnosis made. When I look at populations of patients referred to me, one of the common things we see are patients with a thick heart. That's what HCM means, hypertrophic cardiomyopathy, a thick heart. And the people who did this study looked at everybody sent to them with a thick heart and screened for Fabry's disease. And depending on the country and the population, anywhere from 1% to 3% of the patients with a thick heart were found to have Fabry's disease. If you look at it another way and look at just screening populations in clinics, and that's what this group did. They looked at a series of clinics in this hospital where there were certain indications in that clinic where the patients may be high risk for Fabry's disease. In the neurology clinic, it was cryptogenic stroke and TIAs. And cryptogenic stroke means a stroke that you don't know why the patient had it. They've already done all the normal screening and can't find a reason. In the cardiology clinic, it was looking for hypertrophic cardiomyopathy or a thick heart. Nephrology, kidney clinic looking for renal failure, and they found anywhere from 1.2% in neurology, 1.5% in that cardiology clinic, almost 3% in the kidney clinic. This high number in the ophthalmology clinic is probably not real. We do get them from the ophthalmology clinic, but the point is that a large number of patients in different clinics who present with disease that is suspicious for Fabry's, if you screen those patients, you're going to have a high likelihood of finding it. And in this group of, I think it was 1,300 patients between all the clinics, actually a little bit more, I think it was about 1,800 patients, they found 40 patients with new diagnosis Fabry's disease, and then going back into their families, found an additional 80 people who had the gene. And in that group, as I said when I did my introduction, the majority, cardiac involvement, now that we know what to look for and how to look for it is actually extremely common in adults with Fabry's disease. In this population, 70% of the patients had effects on their heart. The nerves, neuropathy, nerve pain was also very common, kidney disease, eye disease, and neurologic stroke, that sort of thing, again, quite common in adults who are diagnosed with Fabry's disease. And again, this includes the 86 affected family members who were found after the positive cases had family screening. So I'm going to talk now more specifically about the heart. When a patient has Fabry's disease and you begin to store GB3 in the heart, there is a thickening, or we call hypertrophy. The heart muscle becomes thick. This is actually an electron micrograph showing the sort of, looks like an onion skin storage area, very typical for what the GB3 looks like in the heart, and the heart becomes quite thick. The interesting part for us is that it isn't thick because of all the storage material. In fact, only 3% of the increased mass in the heart can be attributed to the actual storage material. The process of the storage material causes the heart to react and become hypertrophied or thickened. And that secondary process is what actually contributes to most of the thickening in the heart. So if we begin with the storage of sphingolipid or GB3 in the heart, it has effects on what we call the endothelium, and that's the lining of the blood vessels of all the arteries that feed blood to the heart. The lining surface is what protects the vessels, discourages the development of plaque, helps the vessels in their reactivity, and that is impaired in Fabry's disease, and that probably accounts for a lot of the what we call atypical chest pain, where you have episodes of chest pain, but we can't find an actual narrowed vessel, and that's probably related to the what we call endothelial dysfunction related to the storage. As I said before, when it's stored in the heart muscle, it causes the cells to thicken and hypertrophy. They get bigger. There actually aren't any more cells. The ones that are there just get bigger, and most of that is not related to the actual storage material, but to the growth of the actual cells, probably because of the storage material being there. Valves. There is some involvement, not very much. Several studies have looked at valve disease. Definitely it does occur and probably related to the effects of the storage material in the structure of the valve, but it's actually quite uncommon. The last is the conducting system. The heart has its own wiring, and that wiring is responsible for conducting the electrical beats that allows your heart to beat at its regular rate or to increase as needed. And there is a lot of effect on that from the presence of the thickening of the heart and also from direct deposition of the GB3 in the heart's wiring. You can almost think of the wiring as the small nerves that run through the heart to carry the electrical signals, and just like the nerves that go out to your hands and to your feet, those nerves become affected by the storage material and the heart's conducting system can start to fail. So if we look at this as an example of some of the things that we look for when we see patients in the clinic and screen them, this first panel is the ECG and the MRI and the biopsy of a normal patient, of a Fabry's patient who was young. This is a normal heart tissue. The thickness of this heart is normal. The size of the heart is normal. Same type of patient at age 42, and these are all untreated patients taken historically. The heart tracing is still normal. The heart is now thicker. The thickness of this wall is much thicker than this wall. There is some white material here. This is called gadolinium. It's what we give during the MRI. We look for the uptake of gadolinium, and now the heart tissue has all these white spaces, which is the storage material taking up room within the heart cells. If we add another 10 years to the picture, it's now obvious the heart is significantly thicker than it was when the patient was in their 20s. There's a lot of this white material here, this gadolinium, which is very classic location in Fabry's. There's lots of material stored in the heart, and now the patient has what we call atrial fibrillation, an irregular heartbeat that can increase the risk of stroke. So going back to presentation, this is showing you the age when person has their first cardiac or cardiovascular event, broken up for males and females, and you will see that there is about a 10+ year shift. Males have their peak by their 40s and 50s, and again, this is historical untreated. Women who are untreated tend to peak almost 10 years later in their 50s and 60s as far as having a cardiac event. And the reason for that is what we call the left ventricular mass, or the thickening of the heart. If we look here, this is showing age and heart thickness, and by age 44, half of all men will have a thickened myocardium, or what we call left ventricular hypertrophy. And the same data shows you that women, this will happen a little less, in about 38%, but almost a decade later in that population. The rate at which the material is deposited is also important. When the heart mass is normal, there is very little change in the amount of material deposited. Once the mass begins to increase, the increase tends to go up very rapidly at about 6.5 grams per meter squared per year. That's just a unit that we use to measure heart mass. Women at about half that rate, but still a significant increase. If we want to compare this to another type of population, if you were a person who had significant high blood pressure and that was not treated, and again, we get this from historical data because we, of course, treat patients with high blood pressure, but an untreated patient with high blood pressure will increase mass at about 5 grams per meter squared per year. So women getting close to that and men exceeding that simply because of the Fabry's disease. So imaging, the commonest imaging that we're going to do is an echocardiogram. That's a cardiac ultrasound, and that gives us lots of information. The reason it's helpful is because if it's done in the same center by the same people, it can be actually very accurate and reproducible. It's relatively inexpensive so that we can easily get it done pretty much anywhere in Canada. The downside to it is that it's not terribly specific. So even though it's helpful to follow patients with Fabry's disease, there is very little about the heart until it becomes very abnormal that the echo would cause us to say, hey, this probably is Fabry's disease. It has to be quite abnormal before that. But for following mass, looking at chambers, looking at valves, it's probably the best technique we have. Again, for the reasons I said, it's inexpensive, it's widespread, and it's easy to use, and it can be very accurate if it's done carefully. MRI is the next thing that we use. If you're living in Ontario, you're lucky because there's fairly easy access. Different provinces, it's accessible at sort of different degrees, and of course in some countries it's just never going to happen, and other countries it's more accessible. Very good for looking at mass. Mass and wall thickness. Normal wall thickness should be 10. This heart is obviously very thick. It's 31 and 29. Very good at looking for gadolinium enhancement, this white material in the wall. The reason we look at this is because this study in 2003, they looked at the presence of gadolinium enhancement in patients with Fabry's and found a very unique pattern that it occurs in what we call the posterior wall, a very specific location, and very few other diseases, although we're finding some now, but very few other diseases have it show up in that exact location. Initially, what we noticed was that patients who had a normal heart mass had very little or no gadolinium, and only when the heart mass became abnormal was there gadolinium enhancement. And this was in the Original papers in 2003. The reason for that, of course, is because there were almost no women in that study. And if you look at this graph here, the top bar, this is men, and this is women. The orange line is the wall thickness at which we would say at this number and above the heart is thickened, and below 12 it's not. And for men, and the green bars are those who have the gadolinium. And so for men, almost nobody who does not have a thick heart has gadolinium. In women, lots of women get gadolinium enhancement before the heart is thick by traditional measurements. So that has spurred our desire to do MRIs more frequently, especially in women. We used to do them less frequently, but because the gadolinium can occur before the wall thickening, we need to be a little bit more cautious and do them more frequently. And the reason we're concerned about this is because we know that when you have a lot of thickening, this here is a measurement of how efficiently the heart contracts. This is time, and this is the amount of fibrosis. And if you have severe fibrosis, even with treatment, the heart function will slowly start to fail over time. So we really want to focus on finding patients before there is significant fibrosis in the posterior wall. In Europe, they actually have this as a recommendation to not start treatment. If there is severe extensive fibrosis, there's a recommendation there to not give ERT because they're not clear it's going to help. We don't have that recommendation here as yet, and there's a lot of controversy as to whether or not that should be a recommendation or not. So far in Canada, it's not something that we do. The other thing that MRI is helpful for is for actually making the diagnosis in patients who present without a known history of Fabry's. And there is a technique which is becoming a little bit more widespread called T1 mapping. And Fabry's patients have a very specific value range for that particular measurement. And it's different than all other patient populations. So this is useful for identifying Fabry's disease in thick hearts. We don't do this in known patients because there's no benefit. If we already know you have Fabry's disease, this value doesn't tell us much. But if you're coming in to be assessed for a thick heart, this value can push the diagnosis in the direction of thinking maybe this patient has Fabry's and we should investigate further. The most recent, and we've only done a few of these here, is the use of something called PET, which is positron emission tomography. It's a type of nuclear medicine scan, and patients who have gadolinium enhancement have it because of inflammation around the myocardium where the gadolinium is building up, and that inflammation is also identifiable on PET, and it can be identified very early. This is an example of a patient who has a MRI with the white gadolinium, and with the PET scan, there's extensive uptake. The benefit of the PET is it probably will see the inflammation earlier than other techniques, and it's also dynamic. So if the inflammatory process goes away, the PET will probably normalize. The downside is we don't have a lot of information on this yet. It does involve radiation, although a small amount, and it requires approval for every case. We've only done a couple here. One of the other things that we use if we're concerned that maybe the disease is very active and there's inflammation is looking at things in the blood called troponin. It's a marker of heart damage. We traditionally use this if you come in with chest pain and an abnormal ECG to see whether or not you may be having a heart attack. In Fabry's, it's not released because of a heart attack, it's released because of the inflammation related to the disease process. And we do see in patients who have who are having cardiac inflammation with Fabry's that they will have a significant increase in the amount of troponin that's released. The downside of this is that if you're a Fabry's patient and you go to emerge with chest pain, they may think you're having a heart attack, and if you're in the right age group, they're going to have to do an angiogram. There's really no way to not do that when you present this way. So I don't want you to think you shouldn't go to emerge, but the presence of the troponin can be confusing, and it may lead to an angiogram to make sure that you're not actually having a heart attack. One of the ways that was common when I started this to make the diagnosis of cardiac Fabry was a biopsy, where they actually go in through the jugular vein in the neck and with a special tool take a small piece of the heart. It probably sounds scary, but it's actually very routine. In patients who've had a cardiac transplant, they get dozens of biopsies over their lifetime because that's how we look for rejection. But for Fabry's disease, it's probably something that's rarely needed and is not done, I think, hardly ever at this point. I've talked mostly about disease in the heart, and when I'm talking about that, I'm talking about the left side, the left ventricle. The right ventricle, however, is also affected. The left ventricle is the chamber that pumps blood to the body. The right ventricle is the one that circulates blood to the lungs, and it's probably overlooked, and that's because it's hard to image and hard to see, but there certainly is effects on that, which may be part of why patients have shortness of breath, because the right ventricle is not functioning appropriately when patients have lots of effect from Fabry's. So heart rhythms are two of the things that we look at carefully in patients with Fabry's, and we screen routinely. Even in children, although very uncommon, this arrhythmia called atrial flutter can occur, and these are going to be patients under the age of 18. Extremely uncommon, less than 1%, but it does occur. These other rhythm disturbances are more non-specific, and they occur in general populations. But this one here is not a normal rhythm in a young person. If we look at adults, much higher. The atrial fibrillation rate in adult patients with gadolinium enhancement is almost 9%. And of those, 13% have already had a TIA or a stroke. It's quite a common rhythm disturbance, which is why we do minimum of yearly Holters even in asymptomatic patients for assessing Fabry's disease. The heart, as I told you, has two main pumping chambers, the left and the right ventricle. Above those are two chambers that are important in regulating heart function and rhythm called the atria, and they're also affected by Fabry's disease. If you look at biopsies of the atrium, which we don't do very commonly, you will see deposition of storage material within the wall of the left atrium. And in some patients, that can, at an early age, cause atrial fibrillation, which is what this ECG is showing in a 28-year-old male. Everything on this patient was normal except for the function of the atria, and that early deposition caused the atrial arrhythmia. We're concerned about this because even in young people, atrial fibrillation is a risk for stroke. Often it's symptomatic. You will feel your heart racing. You'll know something's wrong, but some people don't sense it and it's silent, which is one of the reasons we do routine screening. The other rhythm, which comes from the bottom, heart ventricular arrhythmias, are also very concerning. In patients with Fabry's disease who have fibrosis and lots of ventricular arrhythmias, the likelihood of a serious arrhythmia is very high. And in fact, patients who have fibrosis or thickening and have significant arrhythmias, there's about a 28% chance of a significant arrhythmia and a 10% chance of cardiac death, which is, again, part of the reason why we're very obsessive about doing the monitoring. Now, I'm showing this study because this shows the advantage of long-term monitoring. So if patients are at high risk, we will sometimes recommend a 2-week Holter. This is an implantable loop recorder paper from Europe. We don't have access to those in Ontario. An implantable loop recorder is a small device that's put under the skin and it stays for months, and it downloads the rhythm over the telephone. And it's certainly better than a Holter, but it's simply something we don't have access to. So in lieu of that, if the patient is high risk, if we're worried about a rhythm disturbance, we will order a 2-week Holter. And you don't have to look at all the details, but even in this small population, I should have pointed out it's only 16 males who have thick hearts and fibrosis. You've got 4 cases of the heart stopping for up to 5 seconds, multiple patients who have very low heart rates, we call it bradycardia, several patients with the atrial fibrillation, that rhythm that can be a stroke risk if you're not anticoagulated, and then several ventricular rhythms that are dangerous enough to require having a defibrillator implanted. So long-term monitoring, very helpful in patients who present at increased risk. I talked about the valve disease. It does occur, but it's very uncommon. Disease in the actual coronary arteries, we know that there is deposition in the heart arteries, the vessels that take blood to the heart, but the incidence of actually having a heart attack related to Fabry's disease extremely uncommon in patients with Fabry's. So management, I'm going to actually skip through these slides because you know all this, and I'm just going to talk very briefly about a couple of parts of the CFDI. So you know the trial structure. There basically are 3 parts. Part 1A, which are patients already on treatment, male and female, prior to 2006, and they were left on treatment. 1B, which are patients who are selected by the criteria from the guidelines committee and placed on treatment. And 1C, the patients who are not on treatment either because they don't meet criteria or because they didn't want it. And I'll skip through this one. And what you will see if you look at everybody, actually, I'm going to go 2 more slides down just because I'm out of time. So if you look at everybody, you're going to see that the 1B patients, the patients who are selected by criteria, look to be doing a little bit better than the 1A patients. But when we do this survival statistics, we look for a p-value, and it has to be more than 0.05 to be significant, because there can be random reasons why there are slight differences in populations. And so even though it looks like they're doing better, there really isn't a difference. But if you break this up into 2 groups, males on this side, females on this side, you're going to see that there is no difference in 1A or 1B in the males, meaning that whether you are on treatment because doctors assigned it to you by whatever mechanism was used prior to 2006, or you got on it later because you followed the criteria, there's no difference. In women, however, the women who are assigned to treatment by selective criteria are actually doing better than the women who were placed on treatment prior to 2006. The main reason, although we don't know this, is that probably prior to the CFDI, fewer women got treatment because it was not clear how to select them for treatment and what sort of criteria should be used. But now there are very clearly written guidelines, and I think this is resulting in more women getting treatment earlier on. So I don't have time to do any more, but I can take some questions if you have them.
Thank you, Dr. Iwanochko. That was incredible, and you have a great way of simplifying the information. Does anybody have any questions? If so, write it in the chat section right now, and then I can ask on your behalf. We have a comment for you, though. That was amazing.
Okay.
Any questions at all? Okay, well, you know what, nothing's coming up, and I know that you're, I want to respect your time, so thank you so much for joining us. Excellent.
No problem, thank you.
Very informative.
All right, bye.
Okay, see you later. Have a great day, everybody. Thank you.